SCCT invites you to Las Vegas for SCCT 2022. Over 3 days, July 15th through 17th, attendees can get a complete overview of the cardiovascular CT field. Planned sessions are targeted for all levels, new practitioners and experienced providers alike. Sessions also range from general overviews to state-of-the-art research and expert discussions. Visit scct.org for more information.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I am a radiologist from Dallas, Texas.
And I'm Alastair Moss, a cardiologist in Leicester in the UK.
On today's episode, we will be exploring the latest science out of the ADVANCE registry. As a reminder to our listeners, we discussed the ADVANCE registry on an earlier episode of the podcast in the context of the real-world impact of FFRct.
That's right, Praveen. And joining our conversation today is a very special guest, one of the leads of the ADVANCE registry himself, Dr. Tim Fairbairn. Dr. Fairbairn is a consultant cardiologist in multimodality cardiovascular imaging at the Liverpool Heart and Chest Hospital and a Medical Research Council clinical fellow at the University of Liverpool. Tim, welcome to the show.
Hello, nice to meet you both and the audience.
Tim, thank you so much for coming on. Hopefully, during our conversation today, we can learn obviously a bit more about you, but also about the history and upcoming interesting things coming out of the ADVANCE registry.
Yeah, certainly. I'm looking forward to the discussion. It's a fascinating trial that we've taken part on, and there's lots still coming out of it. So it's lots to learn still.
Excellent. Then before we dive into ADVANCE itself, let's learn a bit more about you. Can you talk to us about your journey into cardiac imaging and how you got involved with ADVANCE?
Certainly. So as Alastair mentioned, I'm a cardiologist in Liverpool in the UK. I do echo, CT and MR, so I'm a sort of multimodality imaging doctor. So I claim that I've got no bias against any modality, so that gives me an advantage, apart from SPECT, obviously, because I don't practice that. I perform cardiac CT, and we were approached, essentially, we're quite a large volume cardiac CT centre, so we do about 2,500 to 3,000 cases a year. And we were approached about the potential to take part in the ADVANCE registry back in 2016. And at that time, of course, I was a few years into my consultancy post, and CT at that time as well was being reviewed by NICE with regard to the diagnostic criteria, and was really being utilised more and more. And it's an exciting area of growth still, isn't it, cardiovascular CT? So we were approached with regards to being potentially using this new technology, and I just thought it was an exciting opportunity. The things that you read about in the publications about the physics of the technology and the implications as to how it could potentially help patient management. And I actually just wanted to try and make this available to the patients. I thought it was a great possibility. And that's why we decided to take part in the ADVANCE registry, really trying to make sure that patients were getting the opportunity to have sort of any new technology available to them, which might benefit them at the earliest possible opportunity. So it was all about trying to make sure that we're getting good patient care and advancing patient care. And I think that's consistent, whatever we do, isn't it? Whatever modality and whatever practice. It's about trying to make sure that patients get the best out of what we're doing.
And just to remind our listeners, ADVANCE stands for Assessing Diagnostic Value of Non-Invasive FFRct in Coronary Care. The intent of informing the ADVANCE registry was to determine the real-world impact of FFRct. And Tim, there's obviously been quite some new data that's come out about how we can potentially use this technology to better work out, which lesions are, going to be the best ones to target for revascularization. And there's been some new work around the translesional fractional flow reserve gradient. I'm just wondering whether you could talk to us a bit about that and how things have gone from looking at the vessel maybe now to looking at the lesion more specifically.
Certainly. So I suppose if we head back to 2016, 2017, when we started using the technology, as you said, ADVANCE was a real world study. Now, it was over 5,000 patients, 28 different centres in numerous different countries across 3 continents. So, it was a real world trial. And when we were taking part in the trial, what's really interesting is because it was a registry study, it didn't mandate necessarily what you did with the result that was coming back. And it was in the sort of the infancy or learning curve of these results. They've been looked at in NXT, Discover, etc., in terms of different trials, but no one had really sort of used it in real world clinical practice. And as we were going along, after a couple of years, we had a meeting between some of the principal investigators linked in with FFRct to try and see whether we could write any guidance in terms of how to use and interpret this technology. And what was fascinating was to find out that we were all doing very similar things in terms of recommendations with patients. Because, of course, when we were one of really only 3 centres in the UK that were using it, and there weren't many centres around the world using it, and certainly not outside of research. So when I was reporting these cases, I thought I was doing the right thing, but you never 100% know whether or not you are doing the right thing. But it felt reassuring that other people were doing very similar things. And this comes to what really related to what your question is. It's called, well, how do we recommend a change in patient management, or what are we going to recommend for patient management with the results that we're receiving? And how do we integrate that into the patient care? And obviously the headline results are with regards to, the fact that it changed management in 2 out of 3 patients, etc. But what we noticed early was the fact that when we looked at the results following the advanced registry, was that even in patients who had a positive FFRct, in actual fact, a lot of them were not going forwards to having an invasive coronary angiogram. So still a minority of those who had an FFRct of less than or equal to 0.8, about 45% actually went on to have an invasive cath. And we saw that this there was an incremental effect, effectively. So the lower your FFRct value, the more likely you were to go on and have an invasive coronary angiogram, and the more likely you were to have revascularization. So if you had an FFRct value of less than 0.71, then you were 71% likely to have revascularization. Now, when we looked at this, we saw that in the grey zone in particular, so between 0.75 and 0.8, that in actual fact, a lot of patients were just being recommended for medical therapy. And we didn't really know, whether that was the right or the wrong thing to do. But you could see that in the results. And certainly that's clinically what I've been doing. And as things have transpired over time, we've started to understand more and more that obviously that was the right decision, and that there are many other factors that we need to consider, not just the overall CT-FFR result. Now, subsequently, we've had data from Emerald looking at this thing called the translesional gradient, which is what you mentioned, or the delta FFRct can have an impact. And we've got data from things like the distal values and the stenosis-specific value, which really do help us understand that getting the result back, you have to interpret it. But in that interpretation, it can then help patient management.
And Tim, what do you think are those key measurable parameters that help decide, whether someone should go down the revascularization route or not? Do you think is it looking at things like that delta, or do you then we're now at a stage where we can start to think about stent planning? Do you look at lesion length or bifurcation disease? How do you actually use all this information in a clinical context?
Yeah, and that's the wonderful thing about Advance, that we're still learning it from the data that was acquired and following these patients. And sometimes it's the real benefit of a registry study over a randomized sort of controlled trial. I mentioned that we sort of got together as a group of PI. So I remember having conversations with people like Bjarne Norgard and different countries and different continents, and us all finding that we were having sort of similar practice in terms of the way that we were managing patients. There was some subtle differences, often between the US and the rest of the world, as to how we were particularly, putting things in reports and integrating this. But that was some of the questions that we had very early on. And really, the majority of us felt that, this was not a dichotomous test. If you've got greater than 0.8, your risk is 0, and you've got less than, your risk is everything. It doesn't work that way. And we've seen that, as I just mentioned, it clearly is a continuum. And that's true of FFRct and invasive FFR. The patients with the lowest values of FFR or FFRct have the greatest risk, and those with the highest have the least risk. But it's not completely black or white. I think one of the first things and most important things that we learned was that a negative FFRct in a value of greater than 0.8 really does confer very low risk. And we saw this in the 90-day data that we published in the EHJ in 2018. Then Manesh Patel published the 1-year data later on. And you could see that the event rate overall was still very low. In a positive instance, about 1.2%. But in a negative instance, again, it was very, very low, 0.6%. And the majority of these actually were non-cardiac related, so not MACE events per se. So So the first and most important thing that I think we found was that, look, if you've got a negative FFRct, you can reassure your patients that they have a very low future event rate, and also the fact that it is very unlikely to be a sort of a cardiac symptom. And sort of further publications have looked at this in terms of the prognostic value. So Bjarne published a meta-analysis which included the advanced paper in Heart this year, looking at that prognostic value over a longer period of time, because I think that's really the data where we're lacking it. And again, it does show that a negative FFRct confers a really sort of good prognostic factor. One of the other things that we sort of picked up early on was that in the original 90-day paper was this anatomical and functional discordance. So one of the reviewers came back early on and said, look, it confuses me as to how you can have patients with sort of mild or minimal disease and yet still have a positive FFRct. And we discussed this at the time as co-authors, and we noted it particularly in the LAD vessel, so whereby in mild, sort of between 30 and 50%, there was a good proportion of patients who had a positive FFRct still. At that time, we were talking about the sort of the diffuseness of disease and overall plaque and the associations, and we thought that was the probable explanation. And subsequently, there's been a paper looking at this specific question. So they looked at the 1,200 patients who had non-obstructive disease, which I think was 43% of the total population. And they've shown that, again, an FFRct value of less than 0.8 still does have a prognostic implication. So we know that anatomy is important, but it's not everything, and that you can still have this diffuse sort of plaque-associated reduction in non-invasive FFRct, and that if you have that, whilst you may not need to send that patient for an invasive coronary angiogram or for a revascularization, but we know that that patient has a slightly higher risk. And therefore, your appropriate treatment may well be that medical therapy, but it just means that you have to do that sort of aggressive medical therapy. And I think in hindsight, that's really what we were seeing in terms of the practice of the main advanced study back in 2018. That this was actually what people were practicing. They maybe didn't have all the evidence from these subsequent trials to show it, but that they were looking at all of this data and integrating it with the CT coronary angiogram and saying, well, yes, this is a positive FFRct, but it's in the distal vessel. The stenosis-specific value is not particularly low, and that you've got that sort of gradual change rather than the big step across the stenosis. And therefore, this patient really isn't going to benefit from being sent for an invasive coronary angiogram or revascularization, but they need medical therapy. And that's really what I think we were seeing. So it's been a fascinating journey the last 5 years, because all the things that we were discussing about, commenting upon in the reviews and the response to the reviews has actually, led to all these subsequent papers later on demonstrating these findings that we've just discussed.
So, Tim, over the span of time, the last 5 years that we were discussing, I think FFRct has exploded in clinical use, both in the States and in the UK. Because of that, we're encountering these far more complex situations, not the simple single stenosis, but serial stenoses with complicated translesional gradients, or, as you had mentioned, diffuse disease that may not necessarily have a discrete focal stenosis. How do you interpret, or how do you approach image interpretation in the context of what we learned from ADVANCE as well as other trials and registries with regard to these more complex situations?
So I try and remember first and foremost that I'm a cardiologist and a clinician. So I think symptoms are very important, and we know that, and we see that from not just from ADVANCE but from other papers as well, that patients with typical angina were associated with higher rates of further future events. So I think symptoms still do remain important, and you have to try and integrate all of these different factors. Is the patient clearly going to be somebody who is maybe amenable to being sent on for further revascularization? And then looking at all these different factors and trying to integrate them with the patient-related factors, the CT-related factors. So Alastair mentioned it early on, do they have high-risk plaque? What's the lesion length? What's the complexity of it? Is it a bifurcation lesion? Trying to put that in terms of guiding whether or not, if revascularization is going to be PCI or is CABG going to be better. Integrating it with things like the delta FFRct or that translesional gradient, because we know that the patients who have a higher translesional gradient from ADVANCE, and then will very similar 0.12 or 0.13 change across that stenosis, and indicates a higher risk. So you're really trying to identify the individuals who are at higher risk of a cardiac event, who are more likely to benefit from revascularization. And then once you've identified that, if they're still getting ongoing symptoms as well, you can be pretty certain that it's going to be the right thing to try and at least recommend that that patient is considered for revascularization. And the next thing I try to think about is, well, how can I help guide my interventional colleagues and surgeons as to what type of revascularization procedure might be the most appropriate? So it's really about integrating all of these different factors from the CT, from the patient, and from the FFRct result into one thing, and that can be difficult, particularly when you're writing a CT report. How do you get all of these factors into the CT report? It would become a very long and complicated CT report, I think, in the end. I mentioned about the fact that when Bjarne and I were having these discussions along with some other co-authors and investigators, the attitude very much of maybe the cardiologist sometimes in putting down the reports was very much put clinical recommendations. By some of my radiology colleagues, and certainly in the States, they felt that maybe putting down recommendations was slightly counterintuitive, well, not counterintuitive, but not to be recommended. So there are different ways of practicing, I think, that's clear. And I don't think there's a right or wrong way of doing it, but I think what's really important is that we understand that the FFRct result is one component, which should be mixed in with lots of different components to try to make that judgment. So a good example is, we looked at factors such as age, diabetes, but the one that we particularly have been looking at is related to this volume to mass phenomenon and sex-related differences. So is there a difference between males and females? Once you start to understand these things related to that, I think that can then help hopefully improve your patient management and actually mean that patients maybe who in the past wouldn't have been selected for revascularization are so, but probably more important, patients who were maybe previously sent for an invasive coronary angiogram inappropriately are no longer done so. And that comes back to the original data that we saw, 25% of patients avoided needing to go for a cath or an invasive, or a PCI when maybe previously they would have been recommended to do so.
So Tim, I'm just interested because the initial concept that I had with FFRct was that it was really there to guide stent or no stent. So it was used to make those highly important revascularization decisions. But given the greater understanding we have of the complexity of coronary anatomy with a modality like CT, and we can add FFRct into that, do you think it also has a role for our preventive cardiologists in terms of how they manage their patients? So is this something that has added value outside of that revasc decision-making process?
I think so, Alastair, yes. That's sort of been my gut feeling for quite a long time now. And that's a reflection of where the papers are coming out from the advanced registry. These are the things that we've wanted to try to explore and understand more. One of the great things about these kind of trials is the fact that, first of all, you get to work with so many great minds and intellectual people, but they're all sort of thought-provoking individuals, and we're all trying to understand the results that we're seeing and trying to see whether we can do better medicine from it and understand it to a greater perspective. And, the black and white cases are great, and that's going to be for a lot of cases, isn't it? We've mentioned that the clear-cut sort of proximal LAD stenosis with maybe a bit of high-risk plaque, a high translesional gradient, and an FFRct of less than 0.6. Great. That's an easy one to manage, isn't it? And equally, the one whereby it comes back and it's greater than 0.87, and clearly you can manage that one quite straightforward medically. But there are going to be a good proportion of cases that we see, maybe 20% or more, whereby it's going to be slightly more complicated. And I think there is a role potentially in this to be able to help us greater risk stratify patients. So I've mentioned about prognostic data. Advance initially didn't have sufficient, really enough events within the 1 year because the event rate was quite low for us to make too much of an assessment or interpretation with regards to that. But I can tell you that the Danish group who have such great data on this patient population actually said, look, we're going to keep on following up our patients because we think this is an important question to answer. So they now have 3-year data, which hopefully will be made available in the not too distant future. That is just going to be such informative data. So I think there is going to be some prognostic value with regards to this. We've seen that. I mentioned the paper looking at the non-obstructive patients, which was presented actually in TCT last year. And they've shown that even if you don't have obstructive disease, but you have a positive FFRct, that you have a higher event rate. Manesh Patel's 1-year data showed that as well, that patients who have a degree stenosis of less than 50%, but a positive FFRct have event rates similar to patients who have obstructive coronary disease. Of course, the best patients are those who have a negative FFRct and no obstructive disease. So yes, it can help predict cardiovascular event rates. how you then use that for management of patients, I suppose, is another question. What difference does it make apart from maybe adding more in terms of risk prediction? The question then is, well, do you treat these patients more aggressively with statin therapies? Do they all go on aspirin automatically? Or do you use maybe PCSK9 inhibitors? And how do we measure that as a sort of a cost effectiveness and a success? And these are the things where I think we're probably going to be going in the not too distant future. I mentioned that other papers that have been looked at in terms of age and diabetes and the utility sort of patient management. And clearly there is a role for this technology within both, all different sort of age ranges, genders, and disease groups. So I don't think it will be specific to one particular group, but I think it will help with several different patient groups and hopefully everybody in terms of future risk stratification.
Okay, so if I were to put that into a final question for you, then has what you've learned from the advanced registry specifically, and with respect to FFRct in general, changed the way that you interpret coronary CT angiography images?
I think it's helped my interpretation, yes. I think it has really helped with the integration and improved patient management. So the short answer is yes, but there's still a fair way to go. It really does help you decide how you're going to manage patients, and it helps you identify cases which you see that you decide, actually this patient's slightly high risk and I want to change things slightly. So yes, it has influenced certainly how I manage patients. Has it changed this direct way that I interpret cardiac CT? Not specifically. I do it very much whereby I report the CT. If I think the patient needs an FFRct, I'll request that it comes back, and then I integrate that into my report. But I don't ever change my original report or my initial findings. I put a conclusion at the end, which then tries to integrate it all together. So I wouldn't have said it's changed my sort of reporting style or the way that I have a standardized approach to reporting and interpreting coronary CT. But it really has helped me understand more about different disease processes and different patients, and influence the patient management for those individuals.
Tim, I want to shift gears here a bit and talk about what the future holds in terms of what we can expect from the advanced registry. So what is the science that you're most excited about that we can expect in the near future coming out of advance?
We touched upon it briefly before, but one of the questions that I really wanted to look at was the differences between men and women, because we talked briefly about the non-obstructive disease, but we know that women are much more likely to come to the cath lab and not have any evidence of obstructive disease, even if they've had a positive functional test. And you see this doing stress echoes or stress MR. We call it microvascular disease. So we wanted to understand that more. And when we looked at it, and we published it a couple of years ago in JACC Imaging, we wanted to look at this volume to mass ratio. So we're looking at the coronary artery volumes and the myocardial mass. And this was sort of as an attempt from CT to estimate things like, not estimate things like coronary flow reserve, but as a comparative. So sort of a supply and demand scenario. And what I was expecting to see was that, the reason why I wanted to look at this was because I thought that CT-FFR might potentially have an advantage because it has the very high sensitivity, but when you see the disease, that FFRct would help you actually make sure that women get equal management compared to men using CT and FFRct, where compared to other modalities, they don't. But what we actually found was slightly opposite to what I thought we were going to find. We found that women actually had a slightly higher volume to mass ratio. And that's because whilst they had smaller hearts and they had slightly smaller coronary arteries, their mass was actually proportionately smaller. And that when we looked at this, it actually did help understand why sometimes women didn't go on and were referred slightly less to invasive coronary angiography compared to men. When we looked at this, the volume to mass ratio was actually a major component to that. So again, people were looking at it, and actually, whilst they didn't have the volume to mass ratio available to them from the advanced registry, clearly it was a predictor of what would happen to the patient and how they would actually then lead on to manage these patients. And subsequently, this has been looked at by several other papers and also in different ethnicities. So I think this sort of additional factor, the volume to mass ratio, if made available to us in a clinical scenario, will really help, again, us be informed in terms of how to better manage these patients, whether it's a microvascular disease or a decision to refer the patients, but make sure that they actually have a correct diagnosis of angina potentially, I think that is the thing that for me is probably the thing that in the near future will be the greatest change for us. And I think that will change how we start approaching the reporting of cardiac CT. Back to Alastair's question earlier, that will have a significant impact. Other things I think will be looking at the percentage of myocardial mass that the coronary arteries supply. I mean, this is not a specific FFRct component, but we know that they use the myocardial mass for the computational dynamic modeling. So why can't we have a look and say, well, what is the percentage of mass that's supplied by that coronary artery? And again, that can help us in terms of making decisions as to whether or not to intervene upon these lesions and the clinical significance of them. So there's just so much data that we can get from cardiac CT, from coronary CT, and with the additional information from the FFRct, that really, you just want to have it all available, because I think more information is power, and that power can only be used, hopefully, in the correct context to try to improve patient management.
Excellent, Tim. And with that in mind, wanted to come to the end of our conversation by asking about what you think the perspective is of FFRct, not only in the UK, but internationally, in terms of its clinical use and its next stages in science.
So somebody once quoted to me not too long ago that FFRct it's a little bit like Marmite. I don't know whether you have Marmite in the United States, but it's a spread that's used on toast in the morning, and it's slightly bitter, and either people love it or hate it. And I like Marmite and I like FFRct. So I suppose if there are camps, I'm in that camp. But the growth in the UK has been phenomenal. Now there are over 80 centres just in NHS England using the technology. The feedback I get is sort of variable, as I think you would expect. So some people feel that it's useful, some people feel that it's not so useful, and that their CT reporting alone is sufficient and gets it right. I think there is a factor of experience. I do think that is true. But for me, if you look at clinically, I still find it useful. And if you look at the evidence, clearly it does improve the specificity. I don't think you can argue against the published evidence, as it is so vast now. The future, where the future lies, is always a difficult one with a crystal ball. But there's a wonderful publication out by Carlos Collett recently, P3 trial, whereby they're utilizing the technology very much more for planning interventions. And they're using the stent planner again for predicting benefit of PCI following a stent implantation. And that's really about, again, using this information that is available to us to really try to make sure that we're improving patient outcomes as best we can do. And we certainly won't discuss the ischemia trial now, but I think the majority of people feel that there is still a role for revascularization outside of just left main stem disease. And it's really about how we appropriately select the best patients who need to go forwards for this versus those patients who optimal medical therapy is the correct thing. And I do think that CT-FFR will be extremely helpful in the future with regards to this avenue. And I think we will continue to learn more and more with regards to this technology as it improves, as we start to use it more. That I think its future is pretty secure in terms of routine clinical use when required for patients who have disease on a CT coronary angiogram. And we know that for sure CT coronary angiography is here for the long term in terms of diagnosing and assessing patients with suspected anginal chest pain. It's class 1 level now in the AHA-ACC guidance. NICE guidance has been around since 2016, and the Europeans are on board as well. So, I don't see that that's going to change.
Excellent. Tim, any concluding thoughts?
Well, we've covered most of them, I'm hoping. But no, thank you for the invitation to talk. There is so much data out there. Sometimes I think it can be difficult to sort of assimilate it all and try to put that in a patient management perspective. But what I think I would say is, look, if people are interested in using technology, then they should certainly try it and integrate it into that patient care. One of the other things we learned from Advance is that there is a learning curve. So, try to talk to colleagues who've got experience in it, read the papers, and implement it in your clinical practice, but implement it having looked at the clinical evidence. There's lots of documents about interpretation, analysis, and how to do that. So that everything is out there and available, but it's like any test. You've got to use it in the appropriate fashion, and you've got to interpret it in the appropriate fashion. And I say that to, my trainees who we teach stress echo, and equally the same with stress MR. it's like any test. It's not foolproof. We as doctors are not foolproof, but it really can help us in terms of diagnosis, prognosis, and patient management. And that's got to be a good thing.
Tim, thank you so much for joining us. It's been a real whistle-stop tour through everything from advanced through to, actually using these type of tools in clinical practice. And it's certainly been a fascinating account that's given me and our listeners a lot of food for thought. Thank you so much for giving up your time to discuss this in the detail that you have.
It's an absolute pleasure, Alastair.
Yeah, seriously. Thank you, Tim. Really, really appreciate it. To our listeners out there, of course, thank you again for tuning in to another episode of the podcast. If you like what you hear from us, please rate, review, and subscribe. Until next time, this is the Donut of Destiny. Cheers.